check, 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 1, 2, 3, check, 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 1, 2, 3, check, 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 1, 2, 3, check, 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 1, 2, 3, check, 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 1, check, 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 1, 2, 3, check, check, 1, 2, 3, check. Check, 1, 2, 3, check. Check, check, 1, 2, 3, check, check, check. Check, 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 1, 3, check, 1, 2, 3, check, 1, 2, 3. अरे ऑन करो ना भैया कैमरा. Check, 1, 2, 3, check, check, 1, 2, 3. Check, 1, check, check, 1, check.
Yes, sir. I'm there. 4 हैं.
लगिए फिर एक ही बार शुरू करें.
Check, check, check. Hello.
Hello,
Are
hello,
we
check.
online? Okay. Good evening and welcome to Kalawati Children's Hospital, associated with the Today we are going to present
Check, check, check.
some cases with a little difference. The difference being that today we don't have a live case here to show, while a case presentation would be done. So that may be little unusual, but sometimes it does happen that cases which you plan to present, they go home because they are better and they don't want to stay anymore just for the class. But these two cases were interesting because they were challenging in terms of the management of case. in addition to reaching a diagnosis. So I have with me Dr. Bhavna Agarwal, who is going to present the cases. So over to you, Bhavna. And with me, I have a faculty with Dr. Kamal Singhal, Dr. Mukesh Dhankar, and Dr. Puneet Sahi, who will be discussing the case along with me.
Good evening, everyone. I'll be presenting two cases today, and I am proceeding with the first case. This child is a 17-year-old female child, resident of Badarpur, who presented to Kalawati Saran Children's Hospital, and the informant being the patient and her father, who was not staying with the child regularly. The patient came to us with a presenting complaint of fever for the past 5 weeks, weakness of both lower limbs for the past 2 weeks, and pain in the upper part of the neck for the past 2 weeks. The child was apparently well. 5 weeks back, when the child started to develop fever, which was low grade, undocumented, with evening rise of temperature, not associated with chills and rigors, and it used to be relieved with medications taken by the patient from the private practitioner. The fever was associated with sudden onset of weakness of both the lower limbs, and the weakness of the lower limbs, they were affected simultaneously, not one by one, and the weakness was noticed in the form of difficulty in walking or getting up from the bed. She used to have the need of support, though she was able to move the limbs in the bed. This weakness was preceded by trivial trauma, which was reported by the patient in the form of fall on the floor.
Dr. Bhavna, when you say it is a sudden onset, what exactly do you mean? Because the onset itself may give us a clue about diagnosis in neurological case. So what do you mean by this sudden? Can you define that, qualify that a little more?
Yes, sir. Sir, in this case, the sudden onset means it can be a vascular event.
No, I'm not asking you the causes. I'm asking you to describe the symptom in a little more detail.
Sir, it will be in hours to days if it is being called as sudden. But in this case, as historically, we will not be able to tell too much about the progression of the weakness, as in this case, the patient is not having the insight into the extent of the illness and the weakness. According to her, she is...
But there must have been some caregivers, so they must have told you whether suddenly the child was not able to move, or it progressed over a period of few hours or days, like an ascending demyelinating situation.
Sir,
so we need to really understand what was happening. Was it that gradually she had difficulty in walking and then she was not able to get up? Was it that on one given day she was not able to get up? Or she had some weakness and within a matter of hours to a day or two, she was not able to get up? Because all three would reflect a different etiology.
Yes. Sir, according to the father, it was within hours to days only when the weakness was noticed, and she required the support to walk. Okay. This weakness was associated with backache, which was dull, continuous in nature, aggravated by movement of the patient and cough, and relieved by hot compressions. There is no history. There is no history of difficulty in hand movements or lifting hand above the head. No history of slipping of the slippers. No history of loss of consciousness, seizures, vomiting, headache, altered sensorium. No history of bladder or bowel disturbances. There is no history of abnormal movements of the body noticed by the patient or the caregivers. No history of tingling or numbing sensation in any part of the body. No history of loss of sensations in any part of the body. She said she is able to appreciate hot water or cold touch when the body is exposed to the same. No history of band-like sensations noticed. No history of visual disturbances, deviation of angle of mouth, drooling of saliva, swallowing difficulty, or abnormal eye movements. There is no history of Cox contact. The patient didn't notice any abnormal or jerky eye movements or swaying to any side of the body while she was walking. There is no history of excessive sweating or abnormal color change or dizziness noticed by the patient. No history of the preceding...
Excuse me, what do you mean by color change?
Sir, in some conditions, if it is associated with autonomic dysfunction, the patient can have hyperhidrosis or anhidrosis or color changes in the form of vasodilatation, flushing, to quantify the autonomic dysfunction in CNS cases. No history of preceding trauma to the spine. No history of prolonged cough, rash, diarrhea or coryza, or bony pains or weight loss, or any bleeding from site. No history of rash or arthralgia.
Why are you interested in the history of bleeding?
So the patient had fever, and associated with the fever, the patient developed 2 weeks of weakness. So to rule out connective tissue disorders or malignancy. In both the cases, we can have thrombocytopenia, and in both the cases, the patient can have bleeding, and both the cases can have some type of, because in this case we have paraplegia or paraparesis. The patient can have compressive myelopathy because of the same cases, and these cases will have associated fever. These are the causes of pyogenic. These are the causes of pyrexia of unknown origin.
No,
So,
tell me one thing. If you have a patient with malignancy or with a connective tissue disorder, how often the presentation would be paresis, and then you would have to ask for a history of bleeding. What will be the more predominant symptom of the two?
So it's very rare. The predominant symptom will be because of there will be lymph node swellings, or visceromegaly will lead to abdominal distension. There will be fever. There will be requirement of blood transfusions. There will be pallor. So bleeding.
So going by your history, would you still entertain these as a possibility? I mean,
No, sir.
I think it's a little far-fetched. And why did your history of contact came so early while you were just describing rest of the symptoms of CNS? You were talking about different cranial nerves, and suddenly there was a history of contact. Any particular reason? It's just that because I'm here, so it stimulates TV as brings it up, or there is any other more specific reason for that?
Sir, when I took the history from the patient, by the first look, the patient had undernutrition. So it suggested some infectious etiology. Plus, the history of preceding fever for the past 5 weeks may lead me to think about the etiology of tuberculosis. And also...
That's okay, but while you are presenting a history, it is very important for all postgraduates to know. If either you are trying to explain the cardinal symptoms. Once you have done that in a chronological fashion, then you look at the comorbidities or other attendant symptoms or a complication of these classical initial cardinal symptoms which are there. And then is what you try to get to a etiological diagnosis based on your history. So history also needs to be structured within it. You start with presenting complaint, you give the individual classical the initial symptoms which have started. After you have done the cardinal symptoms and the comorbidities, telling how much is the severity of involvement of with these symptoms, then you try to get to an etiological diagnosis. So it is always good to have it structured rather than having it jumping from one area to another area.
So in the past history, the patient was shown to psychiatry department 2 years back when she had inappropriate behavior in the form of irrelevant talking, and she used to pick up easy fights at home and school place, for which she was prescribed some drug. According to the father, the name of the drug was olanzapine, and this drug she took for the next 2 to 3 months, and after that she was followed up at the same place, and she discontinued the drug in the next 2 to 3 months. So she took the drug for 4 months, and then she was lost to follow up. After a span of 6 months, she had an episode of abnormal movement of the body in the form of GTCS, which was 1 year back, and for which she again went to some private practitioner and was given some medications, and the seizure attack was aborted. After that, she was not prescribed any long-term medications, or and there was no imaging or investigations was done at that time, and the patient was not told about the diagnosis and the treatment she received. After a span of 1 year, she presented to Kalawati Sarah Children's Hospital with the above said complaints. There is no history
Dr.
of...
Bhavna, so was the patient well from the psychiatric visit, and when she had seizures? So apparently, was she well for this during this period?
Sir, according to the father and the the child, the patient was well. But of the notice, the child left school after she was treated for the same complaint. And according to the father, she left school because of the inappropriate behavior. The father was saying she had the habit of picking easy fights at school place and was having inappropriate behavior. But after that, she discontinued the medications, but she left school. According to the father, the reason
was there a response to the medication what she received in terms of those psychiatric manifestations? Did they respond to that medication?
Sir, as the father said, they left the treatment because they felt some symptomatic relief, and they discontinued the follow-up after that because they thought that the symptom has been controlled, and there is no need to take further medications, and follow-up is required.
I would like you to clarify this a little more. On one hand, you are saying that she had the abnormality of her behavior was being more quarrelsome.
Yes.
right? So she was more quarrelsome, she was not more as social, therefore she left her school.
Yes, sir.
But you are saying her symptoms improved on treatment. Then which symptoms did improve?
Sir,
What was there anything more to her abnormal behavior or behavioral alteration which happened 2 years back?
Sir, irrelevant talking and irrelevant content of the speech, according to the father, was there, which was not there after 3 to 4 months. But the antisocial personality, she used to pick up easy fights at home and school, according to the father. That was the precise reason why she stopped going to school. The behavior, according to the father, improved after taking the medications for the next 3 to 4 months.
I mean, you have not presented the family history so far, but going by the fact that, is there anything else you people would like to ask in this case with regards to their family background? Is there any question which comes to any of the postgraduates? You have anything pertinent to tell us in the family history?
So in the family history,
Or socio-economic history?
yes, sir. There is no history of violence or child abuse in the family, but it is a 4-member family and she is second in birth order. And according to the father, the occupation and the income, she belongs to lower socio-economic strata, and the poverty is there. And here also she was most of the time alone only, and the father used to come on and off to see the patient. So most of the time we used to ask the patient for the history and medications. So maybe the environment given to the patient.
Do you think these symptoms were related to maladjustment in the family, or do you think they were reflective of an organic disease or purely a psychiatric disorder? Because here is a child who had some symptoms, was quarrelsome, left school, then had the seizure, which is not fully investigated, then comes back to you with a chronic, with this long history, then gets fever and gets admitted another few days later, right? Is it a case of neglect of a girl child?
No, sir, because there is no child abuse or neglect or violence at the family home place. And plus the sequence of the symptoms, as rightly said by Dr. Varinder sir, the patient had firstly the abnormal behavior, then it progressed and then resolved with treatment partially, and then she had an episode of seizure, and then she had fever and paraplegia. Can be explained by one illness per se, and it seems that it is having some organic cause.
So how do our PGs see it? The child presented almost 2 years back with some psychiatric manifestations, for which she followed up and she was treated with some drugs. Then 1 year later she has a seizure, and now she has come to you with almost 1.5 months of febrile illness and then weakness. So you think that is it possible that it could be one disease, or is it not? How would you approach this?
Yes, Dr. Satya, what is your question?
The behavior of the child right now, what
That is to be seen, that is to be presented.
That I think will allow Dr. Bhavna to complete her history, and maybe those answers would come. You can retain that for that side, we'll share this one.
Now coming on to the birth history, the child is second in birth order, and the birth was uneventful with no antenatal or postnatal complications. The child attained all the milestones at age appropriate times, and she was studying in class 9th 2 years back, and after that she left school because of the above said inappropriate behavior. The child is completely unimmunized. The child is vegetarian by diet, and the average requirement for 17-year-old girl child will be 2060 kilocalories per day and proteins of 42 grams per day, and she was consuming around 90% of the above said recommendation, creating a deficit of 10%, and she was consuming almost the required amount of proteins in the diet. There is no family history of similar type of illness in the family, no history of tuberculosis or active case in the family, no history of malignancy in the family. The child was born out of non-consanguineous marriage and is staying in a 4-membered family, living in a pakka house with no overcrowding, and she belongs to lower class of socio-economic scale by Kupu-Swamy socio-economic status scale. Coming to the examination.
Would you like to summarize your patient in terms of the history? What exactly do you think we are dealing with? Based on history, what are your differentials? We'll get to the examination, but Based on this history, what all comes to your mind?
Sir,
For the postgraduates, it's always important to hold on to your, you would do everything, and many times one does an examination, gets some finding which may not be very clearly explainable by the history you have, and you may have to review it. But before you get to the examination, even the history, it is always a good idea to consolidate that into the complete story and then look at it, pause and look at it. What does it show? What are the possible etiological diagnoses? And based on that, you may feel a need to ask some more questions for either a negative or a positive history, because remember one thing, patients never attend a class like this, webcast or otherwise, right? So they do not know what is the most important information to be provided. Their information which they provide is related more to the symptoms or a perceived danger of a symptom. Like if they see blood, that's the most important thing. This child will know later on whether it was related to trauma or not. But the fact that patient had pain or was not able to walk, they related to a trivial trauma. So that's the way the common thinking goes, and that is how the natural response to any questions would be. But for you, it is very important to look at that history in totality and see whether there are any missing pieces in this puzzle and ask those questions. So what do you think from your history is the likely diagnosis?
so this is a case of
Can you summarize your history? And
so 17-year-old girl child presented to us with as a case of acute onset paraplegia with no bladder or bowel involvement, with history of seizures in the past, with behavioral abnormalities. The possibility kept was infectious cause as the first possibility, because it was preceded by fever for the past 5 weeks. The second possibility I would like to keep is a demyelinating disease in view of previous history of seizures 1 year back and now presenting with paraplegia. The other possibility can be a malignancy leading to compression in the cord and leading to fever. Fourth possibility is connective tissue disorder, which can be there.
what kind of connective tissue disorder?
So it's rare down in the list, but it can be SLE because patient had fever, patient is a girl, adolescent female, and in a rare instance, SLE can cause lupus myelopathy.
So you're talking of first a lupus leading to a psychiatric changes,
Yes, sir.
a frontal lobe lesion, or maybe, and then leading to a seizure because of a, well, okay. So based on this, why have you not asked about negative history of lupus then, if that's your differential? Because it was rare?
So rare, and I asked about arthralgia and rash, and
You did ask about that. Okay. Any other questions or interventions by the postgraduate chair? Another reason why it is always good to summarize or look at your history is also, suppose your history points to a given diagnosis, then you think of what are the likely findings I should get in this child. So you could more specifically and thoroughly look for those findings if they are not found at the first go. It particularly helps when you're looking for subtle signs, like you kept a possibility of lupus. So if you are looking for a malar rash which is not so prominent, then it may be useful to look at it. I mean, if it is not very prominent, to look at it with more detail or something else. So that is another advantage of summarizing or have a look at your history in its before you get to the examination, because it gives you a lead what to expect.
Proceeding to the examination, the child is conscious, cooperative, the child at the time of examination was conscious, cooperative, lying comfortably in bed, and was able to move all the pole limbs. Her pulse rate was 78 per minute in right radial artery, regular, normal in volume, no radioradial or radiofemoral delay at the time of examination. Respiratory rate being 15 per minute, thoracic in pattern, normal rhythm, no apparent respiratory distress. Her BP was 102 by 70 millimeter of mercury, taken in the right arm in sitting position. Temperature being 37.6 degrees Celsius, taken in the right axil, and she was afebrile at the time of examination. According to the anthropometry, the child was weighing 35.4 kgs, which falls in less than third centile. The height was 150 centimeters, which was less than third centile, and she was having short stature. BMI was 15.73, which was lying between -3 to -2 standard deviation, which categorizes her as having thinness. There was no pallor, icterus, or significant lymphadenopathy, no pedal edema, rash, or subcutaneous swellings, no swelling anywhere else in the body, no sternal tenderness, no neurocutaneous markers as cafe spots or neurofibroma.
Which neurocutaneous disease will give rise to such kind of symptomatology?
Sir, there can be neurofibromatosis type 1, which can have neurofibromas leading to compressive myelopathy, and at the same time they can have CNS manifestations.
Without any cutaneous involvement?
No, sir.
Without any cutaneous neurofibroma? Not a single one? Your child patient does not have anything on the skin?
Yes, sir.
Or does she have anything
No,
on the
sir.
skin? You said no neurocutaneous.
Yes.
Why are you thinking of, okay, what else is possible? Which other neurocutaneous syndrome can present like this? Tuberous sclerosis. With a normal mentation, she was going to school, no seizures, I'll keep it down. Can it be Sturge-Weber? No?
Yes.
Sometimes the hemangioma on the face may be very subtle.
Spinal and yes.
It may be very fine. So you have, if there is a intracranial AV malformation is larger, then you could explain all this by those symptoms. So I would not place her looking for a neurocutaneous mark in the examination away out of the scheme of things. But what is important to remember here is that it's not just a completion tick mark कि अब neurology का case है तो neurocutaneous markers की बात करनी है. What is important is what are we talking of, which neurocutaneous syndrome will present like this. That has to be at the back of the mind again. Then you know what exactly you are looking for. Suppose you are looking for tuberous sclerosis and you are looking for an ash-leaf macule, or at this age maybe a periungual fibroma. You may need a more detailed dermatological opinion maybe sometimes, because you may need special light, wood light, for looking at those macules. So this is not simply that okay, there is a cutaneous manifestation or not a cutaneous manifestation and we try to look for it. There has to be clarity in our thought as to with this given picture what are the neurocutaneous syndrome which could possibly present like this.
Thank you, sir. Proceeding to the systemic examination, the child is a right-handed girl child with conscious orientation and conscious, alert and oriented to time, place and person. Her memory and calculation was normal, and she was having normal speech in the form of fluency, comprehension, naming, repetition and content. But she had a little lack of insight into the extent of her illness. In the cranial nerve examination, the olfactory nerve.
What was the lack of that insight?
Sir, she was while I was examining the child was not sort of aware of the weakness of her lower limb and as we will see, the weakness of the left upper limb also, and she knew that she is in the hospital place for some illness, but she was not aware and she was not telling that she is having weakness of the left upper limb and bilateral.
A 17-year-old child who had significant weakness,
yes, sir.
But she was aware that she was in the hospital, but she did not understand the degree of
yes, sir,
or handicap or
yes,
disability she
yes,
had.
Sir.
Okay.
So in the cranial nerve examination, the olfactory nerve tested was normal. Her vision and color perception was normal. Bilateral pupils were normal in size and normally reacting to light, and the fundus examination done was normal. The extraocular muscle tested bilaterally were normal and moving normally. Corneal reflex was present, and the child was having normal mastication. Child is able to close eyes and wrinkle the forehead, but there is drooling of saliva from the left side of the angle of mouth and deviation of the angle of mouth when she clinches the teeth to the right side. That's explaining that she had left upper motor neuron type of facial nerve palsy. Her 8th cranial nerve was normal and child was able to swallow properly, so I didn't check for the gag reflex. There is no atrophy or deviation of the tongue to any side. Coming on to the motor system examination, bulk of the muscles tested seems to be comparable on both the sides. The tone appears to be normal in the right upper limb. but it was increased in the left upper limb and bilateral lower limbs. The power was 5 by 5 at right shoulder, elbow and wrist joint, but it was 4 by 5 at left shoulder, elbow and wrist joint. The power was 3 by 5 in bilateral lower limb, tested at hip, knee and ankle joints. So she had bilateral paraparesis with left upper limb plagia, paresis. On testing the reflexes, the right biceps, triceps and supinator was 2+, left biceps, left triceps and supinator was 3+, and bilateral ankle and knee reflexes were 4+. And she had clonus in the ankle, bilateral side. Bilateral plantars were extensors and the abdominal reflexes were absent. The sensory nervous system was broadly normal. There were no signs of meningeal irritation or abnormal movement while examination. No cerebellar signs. The skull appears to be normal in size and shape. In the spine examination, there was no spinal tenderness or deformity, but there was a fullness in the right interscapular region, which was measuring 6 by 5 centimeters with ill-defined borders, soft to firm in consistency, with no fluctuation, and the overlying skin appeared to be normal in color and temperature. And there was no sinus or discharge at the time of examination. In respiratory system, the chest appeared to be normal in shape and it was symmetrical. Bilateral air entry was equal and vesicular sounds were heard bilaterally. No added sounds heard. Abdomen was normal in shape. Umbilicus was normal in shape and position. No lump was palpable or organomegaly was there. No free fluid. The urinary bladder was not palpable. S1, S2 was normally heard and were normal in nature. No murmur present. This completes the examination.
So, what is the summary of your with history and examination?
Sir, the child had acute spastic paraparesis with left upper motor neuron type of.
So why is it not that you have left-sided hemiparesis and the right lower limb? Why are you calling it paraparesis and left upper limb involvement? Why is it not left-sided hemiparesis and right lower limb involvement?
Sir,
would it matter?
Sir,
Can you make can one make this distinction?
So the extent of involvement was symmetrical and more in the lower limbs in this case, and it was less in the left upper limb, and plus moreover she was not reporting any symptoms of the left upper limb involvement. So though there was no sequential involvement of the.
When there is hemiplegia of the two limbs, which limb is more involved, upper or lower? Sandeep? Recovery when it happens is the upper limb recovers better or the lower limb recovers better? In hemiplegia, it's the upper limb which is involved. So here you have a situation where upper limb is relatively, and then as she very rightly said that initial presentation it was paraparesis which was reported, and the upper limb weakness was noticed on examination, not otherwise. So possibly with this kind of presentation, where do you think the lesion lies? ये देखिए माइक नहीं चल रहा.
Spinal cord lesions, so compressive myelopathy or any embolic event because there was sudden onset vascular event.
Was it like a catastrophe that suddenly she was not able to walk, and with embolic phenomenon which is only giving rise to a dense, not so dense the hemiparetic symptoms rather than paraparesis? Where is that embolism occurring? Which territory? Which artery? If you are thinking in terms of a intracranial pathology, Your other possibility is
Spinal cord lesion, sir.
spinal cord lesion. Where in spinal cord?
Sir, thoracic number, which where the lower middle.
Keep it closer. It's a high cord lesion or a low cord lesion?
Sir, low cord lesion.
Low cord lesion. Why should there be involvement of the upper limb? And if it is a high cord lesion, the progression, how would be the progression? Will be the progression be the upper limb, lower limb, or lower limb and upper limb? How does the high cord compression progress?
So one-sided first, then second side, then it will
First the one-sided upper limb, then lower limb, and then to the other side, not the other way around. So where is the lesion? Satya? And how are you explaining the convulsion in this child? Neha, why is it important to know the site of lesion? How does it matter?
You got all the deficits. You know what were the deficits? So
and a seizure. So what do you think, where all are the lesions?
So frontal lobe involved.
Frontal lobe. How would that explain paraparesis?
Parasagittal region.
Which if you are, what is the next investigation you're going to order in this child? Most important investigation in this case? Neuroimaging. What in neuroimaging? You can't ask, are you going to ask for the imaging of the whole of the CNS? Spinal cord? Which part of what, are you going for CT or are you going for MRI? And if you, whatever you choose of the two modalities, you'll have to say whether you want of head or of the spine. If of spine, which part of the spine? So from this history, how are you going to decide what you want to do?
please use mic.
Sir, head and brainstem is more important
You think it is brainstem. When there is a brainstem involvement, what is typical of brainstem involvement?
Pupils, reaction.
When you talked of malignancy, you never kept a possibility of a brainstem slow growing. That's a typical thing. You will have multiple cranial nerve palsies. You will have typically an involvement of 9th, 10th and 11th nerves. But I mean, they could be scattered and then have any involvement of the limbs. So brainstem therefore is not the area I'll be very keen on looking at. No, that is true if you are talking of a vascular insult. But if there is a brainstem growth, then that it will not follow any such pattern. You could have ipsilateral or contralateral because that's a growth, and usually it is a bilateral or a very, I would say, not following a particular pattern of involvement. But yes, what is important is that you would have several bunch of 6, 7, 8, 9, 10th on either side getting involved. So anybody else has any clue where the lesion lies? What do you think, Bhavna? Where does the lesion lie?
Sir, the presentation of the patient, it is very difficult to explain the lesion, the condition of the patient by a single lesion. So in this situation, a two-side lesion can be suspected. The patient can have lesion in the brain leading to the behavioral abnormalities and brachiofacial involvement, and as the right upper limb is relatively spared and there is no cranial nerve involvement and respiration involvement, there can be the similar pathology at other place in the spinal cord, lower down, not the high cord lesion, leading to the paraplegia. But that has to be corroborated with the presentation of the patient. The patient has fever for 5 weeks and the
What you are suggesting is a lesion in the brain and lesion in the spine lower down. Then how do you explain the swelling in the paravertebral area which is in the thoracic, upper thoracic? So remember, you have to keep, therefore all your findings in your summary should have been listed out. This all are the problems I have with this child. These are the symptoms I need to explain. These are the signs I need to, or findings I need to explain, and try to fit all that with one pathology and to know what to ask for. So you are missing some pieces and then decided that no, you want, because it's an important thing. What in neuro radio imaging you're going to ask of which area, right?
Yes, sir.
So possibly this is one situation where you would need both, because it looks like there are several skip lesions, all of them are not fitting in, and therefore you would need a neuroimaging of the whole spine as well as of the head, because you would, short of that you would not get the complete information.
Yes.
Right?
Yes, sir.
So you need at least cervical and thoracic spine, and you need the head imaging before you are able to say where all the lesions are and whether they explain
Yes, sir.
the pathologies you have.
This is very important when for the PGs, that when you evaluate a disease, when you are analyzing it, the effort should be made to explain the manifestations with one disease, and effort first. The dictum is to try it, if you can explain it with one site lesion with one disease, that should be the dictum, and that should be the effort. And only when it cannot be done, it is not possible, then you think of two sites or maybe two diseases. But dictum should be one disease, and if one site can explain the deficits, that should be, an effort should be made in that.
Yes.
But in that effort sometimes we underplay the symptoms, like we're trying to do in this case. So there would be situations where you will not be able to explain it by a single lesion. You have a convulsion, you have an altered behavior which says that there is a cranial nerve involvement. You have an involvement of the periphery which is not typical of what you could, one could still explain it by multiple lesion in the brain, more than one lesion on the brain. One side could be at the level of internal capsule where you have right-sided left-sided hemiparesis. Other could just be involving the left-sided representation of the lower lip. It is possible, and maybe something which either it's large enough to involve the frontal lobe or another lesion in the frontal lobe. So you have multi-site lesions, say large NCC, say a large tuberculoma, or a malignancy gliomas which could go anywhere, like, or an AV malformation. But usually the AV malformation, the presentation, once you have the neurological deficits, they are more because of the infarction or the steel phenomenon. They are not because of the pressure effect per se. But yes, you can, not because of the, usually they are because of the bleed and not because of the pressure effect. But it is possible to have sometimes even the pressure effects of the AV malformation where the progression may be slow. So don't only keep one single diagnosis or try only one thing to explain everything if everything is not fitting in. That dictum is absolutely right, provided it answers all your questions. If it doesn't, then you have to go for the second hypothesis, which is either it's more than one diseases, or it's a single disease which has more than one lesions, and it does give rise to a skip lesion. So with that in mind, and there is also fever.
Yes, sir.
Where does this fever fit in? I mean, do you now from your history and examination think that we are dealing with an infective disease, or you think we are dealing with the neurocutaneous disease? Are we dealing with a malformation? Are we dealing with a malignancy? What does it look like to you?
Sir, after reviewing the history that the fever is there for the past 5 weeks, the possibilities gets narrowed down to infectious pathology or a malignancy. The AV
Infection.
malformations.
Which infection continues for 2 years and gives rise to fever for 2 weeks prior to You said past, there was for 2 years this child had
Some problem.
altered behavior,
Yes, sir.
then had a convulsion, had no significant symptoms of fever or inflammation in between. It's only for last 10-15 days this child is having fever, during which time she has developed this neurological deficit. So which infection are we thinking of? Or why not think of a para-infectious illness which may be precipitated or exaggerated by a infection later
Yes, sir.
on. So would you keep a possibility of a para-infectious illness?
So para-infectious lesions leading to transverse myelitis or reactivation of the new attack of multiple sclerosis can be there, but the temporal association of fever with the paraplegia is not there. In cases of para-infectious diseases, the fever or the viral prodrome is typically seen 2 to 3 weeks before the symptoms, and then the patient is afebrile, and then the patient has neurological deficits. While in this case, the patient had fever for the past 3 weeks, continued to have fever during the illness, and had fever for the next 2 weeks when she came and to us with paraplegia.
You kept a possibility of, you talked of multiple sclerosis. Does multiple sclerosis present with altered behavior like this? Does multiple sclerosis present with seizure?
Sir, encephalitis or multiple sclerosis, again the points which go against the diagnosis of them here is that the patient is having altered behavior is there, but there is no loss of consciousness or altered sensorium, so it can rule out encephalitis, but the possibility is kept because it have
No, you are now mixing up ADEM with MS, and ADEM doesn't run for 2 years.
Yes, sir.
So we are not talking of ADEM here. No, that's an acute demyelinating illness, so that's anyway out.
Yes.
You talked of multiple sclerosis, that it may be recurrent, serial
Yes, sir.
sequential involvements, which is possible with multiple sclerosis. My question is that the first 2 attacks which you had, are they typical of multiple sclerosis?
No,
Or
sir.
in other words, what's the usual presentation of multiple sclerosis? Because this child is 17 years. Yes, you can have multiple sclerosis at this age, but what are the common presentation of multiple sclerosis?
Sir, it is a demyelinating disease with waxing and waning course, and the patient can have multiple attacks in the form of demyelination with altered sensorium and
Altered sensorium is not something which is the most important feature in
neurological
one.
deficits are seen.
So you would have either motor neurological deficits, that's one thing, or quite often you have involvement of the optic nerve.
Optic nerve.
So
Yes.
Davik's variant of where you would have more of blindness.
Yes.
So that is a more of common presentation rather than an altered behavior which stays for days,
Yes.
or presentation of a convulsion, 2 of these, which will make this entity highly unlikely in your case. So what investigations did you do in your patient?
Sir, the patient underwent hemoglobin.
Suppose it is an infection. What kind of infection? Sir said, what kind of infection?
Sir,
Is it the infection, or you can have some other explanation for that also? An infection, if suppose it is persisting for 2 years, then what do you think? What could it be?
So it's a chronic infection with latency and then recurrent reactivations. Being in India, the most common cause being tuberculosis.
You mean either there is something wrong with the organism, that it is or something wrong with the body's immunity, and normal organism can also behave in a novel way, that
Yes,
it can have a, depending on, so it could be an immunodeficient child
Yes,
in
sir.
which you can have recurrent or prolonged or these kind of infections. Otherwise an organism like tuberculosis which can linger on for this long.
Yes.
I would keep personally would not agree with the diagnosis of immune deficiency or immune suppressive state, because that usually gives rise to more persistent and more severe infection rather than a indolent behavior. And indolent behavior is, or even, I mean, these are the first 2 times you had no fever, so you hardly can call them as infection. Neither are those 2 presentation like an infection. Even an intracranial infection very uncommonly would present as an altered behavior, and until you are talking of frontal abscess, and heal it on its own, or not have a problem for 2 years. So that way I would rather not be spending my time on looking at an immune deficiency in this context. Yes, otherwise I do agree that if you have an indolent course or you have a recurrent or a severe, I mean, the acronym which is commonly used for immune suppression is that the infections commonly are what we call as SPUR. What is that? Severe, persistent, unusual or recurrent infections. So if you have those kind of situations, then you start thinking in terms of a.
Immunocompromised state.
So this patient would not fit into that.
There are no other indicators to suggest immunodeficiency in this child. No other severe infections.
So the patient underwent hemogram with the peripheral smear examination to see for the anemia of chronic disease or to see for atypical cells.
You want to ask?
In this patient we got it done, and there was no atypical cells. The patient had mild anemia. The other investigation ordered was sputum for acid fast bacillus and MON2 examination. The child had positive MON2 in the form of 15 by 20 mm, and the sputum for AFB was negative.
Is that description of tuberculin skin test complete? 15 by 20 millimeter in duration
Which was read after 48 hours, and it was applied on the right arm. It was
the most important thing in a tuberculin skin test.
So the application and the induration was the induration was 15 by 12 mm, but barring the erythema part. So the induration was there.
What is it? Anything else? Anything else? Strength.
Yeah.
Yes. What happened? You don't think strength is important?
Sir, it is important. It was done with 2 TU PPD, which is available at our hospital, and the other investigations ordered were chest X-ray, since the patient had 5 weeks of fever, and X-ray spine AP lateral to see for any neurological deficit.
Yeah. So we have X-rays to show. Let us put them on the. You start with the chest X-ray full. So what does one see on this X-ray?
So this is a chest X-ray, epilateral chest X. This is
okay. Let us ask people in the audience. Pass on the microphone on the. She quickly handed it over. You could have started very well. Okay, Dr. Deep, what do you think is there on this X-ray? What are the abnormalities you see? Is it normal or abnormal? Huh? Normal, abnormal? अरे इतना तो बता दो भाई, नॉर्मल है कि अब नॉर्मल है?
Patch is looking in the right side, right upper.
Right side?
Right upper lobe, sir.
Right upper lobe, what is there?
Can be breast tissue also.
Okay, you are saying there is a right upper lobe patch. Did I hear you right?
Yes.
Okay. And somebody says there is a mediastinal widening. Okay. So we have 2 inputs. Anybody else? Someone at the back? Ritam, what do you think? Sorry?
On the left side also there is mass. Upper part.
There is a mass. Now we have a third term coming in. There is a mass. So okay.
Opacity.
That means now the 3 questions which need to be answered are: is it parenchymal pneumonia as Dr. Deep thought it was? Is it a paratracheal or a bilateral paratracheal shadow, which means there is a mediastinal widening? And the third thing was there is a mass lesion. Where is the mass, you think?
No, sir, it was opacity, and sir, it is on the upper part of the mediastinum.
Upper part of the mediastinum. You mean superior mediastinum?
Yes, sir.
Why do you think it is in the superior mediastinum? Okay, let us ask Dr. Puneet. What does she feel is there? And
so this is X-ray chest PA view of this child, and we see bilateral homogeneous rounded opacities which appear to be convex laterally and appear to be arising from the mediastinum as the medial margins are merging with the mediastinum. This particular opacity has a greater horizontal spread as compared to the vertical spread, which extends from T2 to T5. This appears more like a mediastinal mass because of the convexity which is facing medially. The angles are acute, suggestive of the mass arising from the mediastinum, and also we have no parenchymal shadows which can be seen in this particular chest X-ray. Sir, could you better delineate anything else?
Yes, what you actually see is when we say there is a paratracheal or is a mediastinal widening, then what you are looking for is that what happens to the paravertebral stripes, how have they gone or they got lifted. What you see here is actually two opacities here. You see an opacity here and you see an opacity here, and this is a very circular opacity which is quite unlike what you would see in a parenchyma. You could see round pneumonias, but you can't have bilateral round pneumonias which are symmetrical. So that makes it parenchyma highly unlikely. In a parenchymal lesion, typically it should get a lobar configuration if it is large enough, or it should have a bronchopneumonic configuration, which this one does not have. Okay. And further on, if it was in parenchyma, then one should have seen an air bronchogram, which again you are not seeing an air bronchogram. If this large consolidation was there in the lung, what has happened to the air bronchogram? You don't see any air bronchogram, which makes it highly unlikely to be in the parenchyma. That means, is it in the mediastinum? If it is in the mediastinum or a lymph node like that, then why should that lymph node be this circular? And usually commonest reason here would be either a lymphoma or a tubercular lymph node. Both would have a contiguous spread. The lymph nodes run in chains, right? So they should have more vertical spread rather than a horizontal spread, which makes it little unusual. It is too well rounded. Okay. Another way you can differentiate between a parenchymal lesion versus a pleural based lesion. Now, is it a pleural based lesion? Yes, no. No, it is not a pleural based lesion. Why? There is something called as a mediastinal pleura. You are only think of a parietal pleura. So you think, since it is not coming here on this side, so it is not arising from the pleura. Why is it not arising from the mediastinal pleura here? Yes?
Sir,
Louder?
so there is one term we can use, that is egg on carpet appearance and egg under carpet appearance.
So what do you think is here? Where is the egg?
The egg on the
There are a
carpet.
couple of eggs here. Now, where is that egg now?
The egg on the carpet.
You think it is egg on the carpet?
Yes, sir. Because if it arises from the pleural base, then it should be under the carpet appearance, and the margin should be convex, not the concave. The angle should be convex, not the concave.
Okay. So if I would say this is, if taking on what you have said, which is partly correct in terms of description of the sign, but not description of this X-ray. So let me take it further. What Dr. Preetham mentioned was that there is a description called as egg on carpet and egg under the carpet. And that distinction you make whether there is a parenchymal lesion or a lesion which is arising from the pleura. A parenchymal lesion would have an acute angle, like you have an acute angle on this side, but this is actually arising, the base is here. So the question of whether it is on the carpet or under the carpet is here, carpet is not here. So this angle is not valid. I am just showing this angle to explain what I mean by an acute angle. So if it was a parenchymal lesion which was arising here, then here on the base it should have made an acute angle like this, right? Which it is not. What it is making is a rather an obtuse angle each way. It is mixing up. It's not. So it's a mediastinal pleura possibly which is lifted, or a paravertebral stripe of fascia which is lifted. It could be even be a paravertebral abscess, because you people have talked of, Dr. Bhavna did mention about a swelling on the which side? Right side.
Interscapular area.
Right interscapular area, and this is the interscapular area. So remember, there is always a case of a missing third dimension when you talk of X-rays. When we talk of X-rays, this dimension is always missed, because all this gets onto that 1 millimeter thick X-ray film. So this shadow may be appearing anywhere from outside to inside, right? So remember, it could be coming from skin, pleura, parenchyma, bone, or at the back even for the paravertebrae, or behind, I mean, on the skin which at the back. So this is what is important to remember. But what about this other shadow? Where is this arising from? Is this a lymph node, or is it, because we are now talking of a paratracheal lymph node, and that if we say in a chronic fever paratracheal lymph node, TB becomes an easy diagnosis. So this shadow, what does this look like to you? Is it a lymph node? Is it something else? I have been using the cursor which is visible on the screen, otherwise on screen. So there we have a request that I have to show it on the screen, so you would see carefully. We are talking of this circular lesion here, mass-like lesion here, which has a counterpart on the other side, and in addition we have another lesion which is this one, okay, this one here. So now, having talked of this that it looks like an obtuse lesion which is coming from the mediastinal pleura maybe, and this is bilateral. Now I am concentrating on this lesion, and my question is it a lymph node or is it arising somewhere else? Usually lymph node lesion in the chest are part of which mediastinum? Anterior, posterior, or middle? Lymph nodes are part of which part of the mediastinum? They can be anywhere, but usually when we say paratracheal or mediastinal lymphadenopathy, which part of the mediastinum are we referring to? Middle or anterior? Right. So when you say T cell lymphoma, terrible 4 T's for anterior mediastinum: thymus, thyroid, teratoma, and terrible T cell lymphoma. That's how you remember those 4 T's, na? So that lymphoma is, where is that arising? It's a lymph node, yes, right? So anterior mediastinum is also a lymph node. Now remember, on a PA view, once you see clavicle, this at clavicle your anterior part of the mediastinum has ended. If this shadow is going above it, it cannot be in anterior or middle, it is most likely in the posterior mediastinum, right? So therefore this could even be a paravertebral abscess. This is not, it's in the posterior mediastinum. So possibly it's a posterior mediastinal lesion. So it could be an abscess, maybe a neuroblastoma. You could explain almost all of your symptoms by a neuroblastoma. It's a slowly progressive malignancy. It can give rise to subcutaneous swellings. It can have an intraspinal extension, can give rise to compression. It can give rise to convulsion by hypertension or a paraneoplastic explanation, and that would can also explain the confusion or the psychological changes this child have. So if there was a malignancy, I would keep possibly that would be a neuroblastoma, though possibly the picture on X-ray would be different, because this degree of symmetricity on both sides and mediastinal pleura based lesion would not be what you would see with neuroblastoma. That would have been more diffuse and invasive, going all over, right? So based on this X-ray, all you can say is possibly you have some abscess or a mediastinal based lesion there. That is why I am calling it an abscess. And you also have a paravertebral lesion which could be, which needs further delineation. So what other investigation you can do to delineate this lesion?
Third dimension, the lateral chest X-ray.
You want a?
Lateral chest X-ray.
Lateral chest X-ray. Okay, let's have a lateral chest X-ray. How does lateral chest X-ray help?
Sir, here we'll be able to see the posterior mediastinum, and if any lesion is there, the impact of that lesion on
simply you are trying to get the third dimension which you lost in the AP view. In the frontal view, this dimension was lost. In lateral, this dimension will come, and everything on cross axis or trans axis will get squeezed or superimposed, right? So this is what, and when you join the information from, you combine the information from a frontal and a lateral view, you are able to put those lesions into where they belong. It's something which is not very commonly used these days because CTs are easily available, but remember, CTs are roughly, even in the best hands, still about 30 to 40 times an X-ray, usually about 100 to 200 X-rays, and a lateral view is just 3 times the frontal X-ray. So it's far less radiation than a CT. If you are able to get answers, yes, no, why not? And many times cost is also an issue, like in our case. So first thing we did was a lateral X-ray. And what does that show?
This is the lateral X-ray for the same child, and it shows a mass in the posterior part of the upper chest, probably the posterior mediastinum, which appears to be compressing on the posterior part of this trachea. The tracheal lumen is wide in the upper part. Then over in this area, it appears to be narrowed down and compressed from behind. And then down again, the lumen appears to be normal. So there appears to be some compression which is coming from the posterior aspect.
So what do you think this is? Anybody? So you are thinking in terms of a posterior collection, which is where is that collection? It's a retropharyngeal or prevertebral space. So this is where the retropharyngeal will come up. It's little lower down. Retropharyngeal abscess is more often in the neck rather than in the mediastinum, but it seems to be going up to the neck because you already see this compression. If you can see the upper end of the compression, please. It's little up. It's going up. The compression starts somewhere here, which is almost outside the thoracic cavity. You see, because of the superimposition of both arms, we lose the context. This is where the rib cage has ended. So this part of the trachea is not within the thorax, it's in the neck. So it's starting from the lower part of the neck and going down. So it could be a retropharyngeal abscess in the prevertebral space, which is continued and dragged down. Do you have any comment on the vertebra? Normal, because you have a child with paraparesis. Why is that nobody has tried to look at the vertebrae at all? And also at the space between the vertebrae. That could have given you some idea about whether there was a compression here or not. Are you able to clearly see them? So remember one important thing. The same X-ray cannot give you all the answers. If you can't use a lateral view of the chest as a lateral view of the spine. The radiological factors which are used are very different. You need more penetrative X-ray to look at the bones, and you do not want a more penetrative X-ray when you are looking for a chest, because there you want to look at the parenchyma. So the radiological factor which a radiographer is going to use are going to be different. The windows, if it is a digital X-ray, are going to be different, and therefore our effort to comment on these would be compromised by the type of X-ray which has been provided to you. That doesn't say that you should not look at the spine, but what it does tell us is that you can't be sure of what you have seen. So if you see a lesion, fine, you can further qualify it. If you do not see anything, that does not mean it rules out a lesion in the spine, because this is not a lateral view of the spine, it is a lateral view of the chest. Is that distinction clear? Let's go further. So what more investigations did you order?
Sir, we ordered CECT chest for this child with CECT brain to see for the etiology.
So now we have CT chest, and this will help us understand the X-ray better, right? So though we did not do the CT just to understand the X-ray better, but since we have both, we'll try to link these two. So please tell us what are the findings on the chest CT.
Okay, so this is CECT in the upper part of the neck and at the level of C2, and anterior, this is a transverse section, and this is the anterior and the posterior end. This is the C2, C3 vertebral body, and in front of the vertebral body, over here anteriorly, this is the pharynx, and just posterior to it, we see two hypodense areas surrounded by slight enhancement. So you have two circular hypodense lesions on either side, just behind the pharynx. These appear to be like the retropharyngeal abscesses. When we went further down, we have a transverse section at the level of T4 vertebra, and over here we see this is the T4 vertebral body This is the spinal canal. This is the posterior process, the spinous process. Just in front of the vertebral body, there is a large hypodense area. This is the prevertebral abscess. Over here you see the trachea has divided into the two bronchi, and over here laterally, bilaterally we see hypodense areas. These are the paravertebral abscesses. The next one is CECT chest. This is the lung window, and over here we see that no parenchymal lesions can be seen. The previous two CECT scans that we had were mediastinal windows. So this is a mediastinal window where the mediastinum is seen better as compared to the lung shadows. And the next one over here we have the lung window in which no lung parenchymal lesions can be seen.
So when you read CT scans, first look at the mediastinal window and look for the lymph nodes, the mediastinal part, and then go on to the lung window. They give you very different information. In a mediastinal window, you will not be able to comment on the lung parenchyma, and in a lung parenchyma, in a lung window, you will not be able to comment on the mediastinal part. So what the CT is doing here is what sir said. In an AP X-ray, what you get to know is that the lesion is on the right side or on the left side or up or down. It will not give you the depth. Okay, and the lateral X-ray gives you the depth. It will tell you whether it is an anterior, posterior, wherever it is. So this is what we have in CT scan.
So CCT head was simultaneously ordered because the child had one episode of seizure also apart from the abnormal behavior, and it showed.
Okay, so this is the CECT head, and over here we see in the right frontoparietal area, there is also a transverse section. In the right frontoparietal area, we see a ring enhancing lesion which has irregular borders, appears to be around more than or equal to 20 millimeters in size, which is written in the X-ray report, CT report, and there is surrounding area, significant area of perilesional edema. So this was highly suggestive of a tuberculoma.
So what do you think? Is Dr. Puneet right? Is it tuberculoma or is it something else? Now we have a ring enhancing lesion here. What is it suggestive of? What do you think? Points in favor of what? You are saying it is likely to be neurocysticercosis. It is likely to be tuberculoma. Why?
We have a split now. Somebody says it is NCC and somebody thinks it is tuberculoma, and somebody thinks it's NCC. So, Dr. Bhavna, how do you differentiate between NCC and tuberculoma?
Sir, NCC is generally tuberculoma is generally a large lesion, and the distinction is given roughly around 20 mm conventionally. For if the lesion is more than 20 mm, it is tuberculoma. If it is less than 20 mm, it goes in favor of NCC. Secondly, if the lesion is ill-defined and single and without scolex, then it goes in favor of tuberculoma. A lesion with significant perilesional edema also goes in favor of tuberculoma, while NCC will be usually multiple with a scolex, smaller in size and with less amount of perilesional edema.
Using these distinctive points which you referred to, what do you think this CT shows?
Sir, this
there is one more thing. Look at the outline.
Yes, sir.
Is it well defined? Is it?
Yes, sir. Yes. And sir, in this context, since the child also had other lesions in.
Forget that. Let's talk only of this.
So this seems to be more likely a tuberculoma, as the patient.
Because it's larger in size. Because
perilesional edema.
There is a huge perilesional edema.
There is no scolex.
And the surrounding area, I mean the boundary also looks irregular.
Yes, sir.
Shaggy. Okay. Let's see more images.
Next we ordered. So next
do
we
you have
ordered.
any more images to show?
So we have gone through CCT chest and head, and next we ordered MRI to better delineate the spinal cord and the vertebral bodies to see for the extent of involvement and to see for the right cause of paraplegia.
So what do you see here?
This is the MRI of the child, sagittal view, and over here we see a hyperintense lesion which is seen extending from the C6 vertebral body up to the level of T2 to T3 vertebral body, and it is significantly compressing the posterior part of the trachea. We also see hyperintense lesions, skip lesions in the vertebral body. For example, this C3 vertebra is hyperintense as compared to the other vertebral bodies which are seen. Posteriorly, we see this is the spinal canal, and within it is the spinal cord. And we see that over here there is also compression of the spinal cord which is extending from T1, T2, T3 levels. From C7 to T4, T3 levels, there is compression. Anteriorly, there is compression of the spinal cord which is present.
I would just give a word of caution here because it's not dead central, it's an oblique cut. So sometimes it can be deceptive. I know you know it from the other cuts, but on this cut, it's to conclusively say there is an compression of the cord is difficult because the whole of the cut is not going through the spinal canal. The other area, the spinal canal, is just not visible, so it's not an obstruction there. But we know from the other cuts, yes, there was a compression. What about the coronal cuts?
The coronal sections, as showed in the image, shows two lesions which are situated paravertebrally with hyper intensity and with more so in the wall of the lesion. So this can very well be the paravertebral abscesses which we were talking about in the CCT and the X-ray.
Now you can actually imagine this as what you were seeing on the
chest X-ray and CT.
On the chest X-ray. You remember we talked of egg under or egg over the carpet, and now you can see this is obtuse and not acute, so it is not in the parenchyma, it is coming from the periphery, though it is not, now we know it is not actually coming from pleura, it is in the from the paravertebral area, but there is a pleural reflection there also. There is a collection here and possibly a collection which you see here. So it's a possibility that it's a huge collection which is running from C6 to T2 level, which is extending both in vertical as well as horizontal axis, but it's more in the horizontal axis, it's more at the lower part of the in the thoracic cavity rather than the cervical area. So it has an anterior posterior projection which is compressing, and there is a lateral projection which is lower down, maybe possibly a gravitation, or maybe it is a multiloculated collection. And with this possibility of an abscess, what will you think of? Do you think this child has a retropharyngeal abscess which is pyogenic? What antibiotics or what treatment would you consider in this child?
So since we have, firstly, if possible, we'll try to make a microbiological diagnosis for the case.
How will you make microbiological diagnosis in this child?
So in this child we had a positive MON2, and since the child...
Not a microbiological diagnosis.
So the child had a swelling also at the back, which was there in the interscapular area.
Very good. We have an accessible lesion, so you don't only look at the deep-seated lesion, you have an accessible lesion.
Yes, sir.
So you can try while your X-ray, now this MRI does not show a collection in the back area. It shows thickening of or an edema. There is a thickening or edema of the subcutaneous tissue here, but it does not truly show a collection. Here. Though the section has also cut down because of overlapping two things, but that's what it is showing. So you would like to put in a needle here?
Yeah. No, sir. So actually on examination the swelling had no fluctuation. It was a swelling. So before putting a needle directly, since it is involving critical structures, the spinal cord and the paravertebral areas, we sought help of the ultrasonography in this case, and we saw the collection was deep-seated, and through the ultrasonographic guidance, we did a needle aspiration from the prevertebral abscess and the paravertebral abscesses, and send the sample for microbiological diagnosis.
You did not find, though, that there was a peripheral lesion. That peripheral lesion was just an edema. It was not showing any collection which you could have aspirated.
Yes,
So you went ahead, you did an ultrasound guided
Aspiration.
deep-seated aspiration from the paravertebral
Yes.
abscess. Okay.
So the further course of the patient, the sample was sent for bacterial culture sensitivity gram staining, acid fast bacillus visualization, and since we have this new advent of gene expert, the sample was sent for gene expert also, and within a day the report came to be positive for mycobacterium tuberculosis and rifampicin sensitive, and the child was started on steroids plus category 1 ATT. Since the child also had periregional edema in the CNS tuberculoma leading to symptoms and spinal tuberculosis leading to paraplegia, so child was started on steroids plus ATT, and the child symptoms as well as the radiological findings resolved with the treatment, and the child is under our follow-up and is doing well with the treatment.
Now, in this management of this child, you have mentioned only ATT. Would you have any concerns in management of this child?
Yes.
You got a molecular diagnosis which was fast, but then still it raises a question. Tuberculosis continued for 2 years without any treatment, without any complications. Is that usual story?
No, sir. In this case, we had to take opinion of a number of doctors. It included interventional radiologists.
That's about management of your case. I'm not asking you that question. My
Yes,
question is, your final diagnosis is tuberculosis based on gene expert, which is kind of very specific test, and therefore we are not questioning it.
Yes.
And it was a clinical possibility. The pre-test probability was also high.
Yes.
But my issue is, does it explain all the symptom by one etiology? Dr. Kamal and I had a variation of opinion earlier when we started. We had a difference of opinion. He said we should try to explain everything by one etiology and one lesion. Where I said many times you would have a situation where you will not be able to explain by one
Yes.
lesion. Now is the point of debate here is, can it be explained by one etiology? Do you think her tuberculoma or the lesion which you see in the brain is not a healed NCC which gave rise to her psychiatric manifestation, and now she has developed TB, or do you think that was also tuberculoma?
So that was also tuberculoma, as we have seen that the morphology of the lesion is like tuberculoma, and the lesion is in the frontoparietal area, right side, and the deficit which we see here is left upper motor neuron palsy of 7th nerve and left-sided upper motor neuron paresis. So that can be explained, plus the frontal lesion can have manifestations in the form of abnormal behavior as seen in our case, in form of inattentiveness, inappropriate behavior, inappropriate fights, and the other manifestations of the abnormal behavior. So this can be very well explained by a single etiology.
While I would agree with you in terms of that this lesion could possibly explain her psychiatric behavior or behavioral alteration because of the frontal lobe, but I don't agree with you that this will explain her upper limb involvement. For upper limb involvement, the answer possibly lies in the spine. You have a C3, C4 level vertebra which is gone, which means you are already dealing at a level of C4 or C5.
Yes, sir.
So C5 below you have compression of the cord, you have a paravertebral abscess. Possibly the upper limb lesions are because of the collection there, which will also be upper
Yes, sir.
motor neuron because of the pressure on the cord and on the tract. We haven't found a specific cutoff to say, as one would expect in a spinal case, of a area where you would have a lower motor neuron or a sensory cutoff, which is sometimes possible when the sensory compression does not happen. That's explicable. I don't think. Do you have anything?
Only thing that we have to weigh our options. Either it is a high spinal cord lesion leading to one upper limb involvement. But the thing is that had it been a significant spinal cord lesion, it is less likely to affect only one upper limb. Then both should be involved. Because it is one upper limb, then we have to weigh our option whether it is a lesion up there affecting the frontoparietal region leading to the upper motor neuron type facial and the upper limb. Had it been a significant high cord lesion leading to upper limb involvement, then some involvement of the other upper limb is also expected.
So the other question which I have for you is that can tuberculosis stay for 2 years without treatment like this? Have a indolent course? Obviously the simple answer is yes, because
Natural
there is
history.
a situation where you have proven it microbiology. It's rare, it's uncommon. It's uncommon. The only thing which you could possibly think of is that tuberculosis, even in the pre-chemotherapeutic era, would heal in about 1/3 of cases. Right? So people were healed on their own in about 1/3 cases. The death rates were high when you did not have chemotherapy. The only difference between a treated case and a self-healed case is the level of the chances of having a relapse is much higher if you do not treat. So possibly she had a lesion which healed on its own, and then she had, because there were multiple lesions, and then she had progression of a reactivation in some area which had initially got contained by her body immune response. This is just a hypothesis. I cannot say with surety or certainty, but that's what it looks like, given the fact that we had a microbiological diagnosis and this child improved in follow-up, including her psychiatric behavioral changes and her neurological deficit, everything improved. But one of the concerns which always one has is that once you start treatment of tuberculosis, you have paradoxical increase. You had a significant airway compression. How did you deal with that? You haven't talked of anything on the airway compression. You have still decided to manage it conservatively. Can you explain that to us?
The child was asymptomatic. She didn't have any complaint of dysphagia or difficulty in respiration. And other than that, with steroids and category 1 ATT, and with especially, we also took spinal, the child also was prescribed spinal immobilization for the spinal pathology. So conservative management was continued to see for the response for the next 4 to 6 weeks, and she was explained about the danger signs of paradoxical increase. If it occurs, she should come immediately and report to us so that any neurological intervention can be sought. So we went with medical management in this case with orthopedics referral, and other than that, she was explained about the danger signs.
You see, the important thing to remember here is that the dictum for a retropharyngeal abscess is you always drain a retropharyngeal abscess. You don't wait for it to heal by itself. It does not in most situations. The dictum is that you have to drain a retropharyngeal abscess. The commonest retropharyngeal abscesses which you see are not tubercular, they are pyogenic. They are much more acute presenting, and that is why the dictum of draining of retropharyngeal abscess comes, because you are dealing with an acute pyogenic. Otherwise it will rupture and cause mediastinitis, and that's a much difficult and much more dangerous situation. Here it was a retropharyngeal abscess which is described in the literature, but much less commonly with tuberculosis, wherein also you could do a drainage, but it's not a simple retropharyngeal abscess. It's a retropharyngeal extension of a prevertebral and a paravertebral tubercular abscess. That means it also had as an extension into the spinal cord. How do you drain a retropharyngeal abscess? You just make a nick in the pharyngeal wall and everything drains out. But then that also makes a connection. Right? If it is pyogenic, you have given antibiotic, it will heal immediately, and therefore it is localized to that area. Therefore, there is not significant spread. Here it is already communicating, including into the spinal canal. So if we attempt any drainage of this retropharyngeal abscess through an intraoral route, there was always a possibility that we could have, and it's tubercular, therefore would not have healed immediately. There was going to be a continuous tract, and we could have now introduced any infection into the spinal cord. That would have been actually very, very dangerous, and that was why we opted towards using steroids and a conservative approach, and followed up and see what happens later on. And thankfully the child responded. Instead of going into a paradoxical increase, which is much less common, she went into healing, and slowly this abscess is getting resolved. So this is an important thing to remember, that this was indeed an atypical presentation, and this was something where there were issues not only towards diagnosis but also about management, and we thought it was important to share. since we are already reaching to the Cinderella time of 6 o'clock, right? Should we go for the second case? Before that, are there any questions or comments? Yes.
You mentioned about gene expert. Could
Yes.
you just tell what is this gene expert?
So,
Rather than taking a brand name, can you just tell me what this is?
so gene expert is a technique which uses specific genes to recognize mycobacterium tuberculosis. At the same time, it detects resistance to only rifampicin, and the results can come within 2 hours if properly applied. The other thing, it is totally machine operated. It is not having any manual intervention. So possibility of cross contamination plus possibility of environmental contamination is less. So after sending gene expert, we should try to send the sample for culture. Since roughly said estimate is 40% of the samples are culture positive, 28 to 29% are gene export positive, and 10 to 12% are microscopy positive in cases of sputum samples. And the sensitivity of gene export for samples other than sputum and cerebrospinal fluid like peritoneal or pleural and other tuberculosis will be having negative gene export. So
I just to put the whole thing into little more clarity. The gene expert is the technique or platform on which several molecular based diagnoses are made. When you use it for TB, the trade name is called ExpertRif. Trade names are not important. Currently, this is the only one available, so it's like semantics with the generic name. The generic platform is also called CBNAR, cartridge-based nucleic acid amplification test. So it's basically a PCR, but it's a nested PCR. That means you have simultaneously 2 PCR linked. It's a real-time PCR where you are looking at the ISC or Ramanujam. I do not know whether it is true or not, but that great mathematician is said to have made a mistake while crossing a river, that he looked at the average size of his family and said that everybody can cross, while obviously his children were going to drown. I doubt this is true for Ramanujam, but this parable is around. We heard about that. So when you talk of averages, it hides the extremes. It does not tell you. You have to look at the extremes and the variations within what contributes that mean. So the utility of this test is, if it comes positive, you are most likely dealing with TB. But if it comes negative, you still cannot rule out TB. That's what it goes on to say. Since it's cartridge based, the positivity is the false positivity is low, and therefore because of contamination is low, you are pretty certain. It's a real-time test. It is a big advancement because you know the answer in about 1.5 to 2 hours the moment you set the test. So many of you may have noticed while I was taking this class, I was attending to my phone. These were 4 times I got a SMS from our lab on the gene expert samples which were sent today morning, what came positive. So I was just looking at them. One of them had some complications, so I went to tell that patient should not be sent home, we will have to repeat the sample. So that is a possibility, and that is what is available, possibly going to be available under the program in our country too. Having said that, let's look at the other case which you have lined up quickly, and then we'll try to summarize and see how these 2 abscesses figure out.
in onset, gradually progressive, not associated with abdominal pain or vomiting or diarrhea or obstipation. There was no swelling around the eyes or legs or any other part of the body. It was not associated with jaundice or prolonged cough or breathlessness or burning with duration. There is no past history of blood transfusions or jaundice, no history of recurrent pneumonias or infections or diarrhea or ear discharge, no previous history of hospitalization or any other significant medical illness in the past. The birth history, developmental history, immunization history seems to be appropriate for the baby. Nutritionally, the baby consumes nearly about 80% of the calories, creating a deficit of 20%. In the family history, the child belongs to there is no history of tuberculosis in the family or malignancy. The child belongs to a lower socioeconomic state of socioeconomic strata. In short, in the history, the patient had fever for 10 days and abdominal distension for 7 days, not associated with bleeding from any side, jaundice or swelling over any other part of the body like eyes or foot, not associated with rash or arthralgia. So proceeding to the examination, the child was a sick looking child when I examined the child, comfortably on bed and alert, conscious and cooperative with a high grade of temperature running measured around 103 degree Fahrenheit, vitals being stable with slight tachypnea and tachycardia that was attributed to fever with normal BP, and the anthropometry interpretation for the child is the child belongs to grade 1 IAP malnutrition with short stature with normal BMI. The child had severe pallor on examination with no significant lymphadenopathy or petechiae or sternal tenderness, no pedal edema or vitamin deficiency signs. On systemic examination, the child had positive findings in the form of the child had generalized distension of the abdomen, which was with no obvious swellings to any one quadrant of abdomen, with hepatomegaly and splenomegaly. The liver was palpable 6 centimeters below the right costal margin, which was firm in consistency with smooth surface and regular margins, with splenomegaly which was 6 centimeters below the left costal margin along the splenic axis, which was firm in consistency, which was non-tender and with splenic notch palpable. Other than that, the child didn't have any ascites or visible peristalsis or visible pulsations. Rest of the systemic examination was normal. The child didn't have any respiratory findings in the form of Krebs or added sounds. There was no CNS involvement in this case. The child was a case of fever with splenohepatomegaly, with anemia, with short stature, with no jaundice or significant lymphadenopathy, no ascites, and the possibility of malaria was kept at the time of examination, admission. The other possibility kept was malignancy, enteric fever, chronic infections like tuberculosis or HLH, and the investigations were carried out to see for the differential diagnosis.
Why did you, of the differentials which you refer to, why your first was malaria, second was a malignancy, and third was typhoid. Why this sequence?
So it was the case was pre-morbidity normal, and the child had a short duration, symptoms were for the short duration. They were just lasting for 7 days and 10 days. And the fever and splenohepatomegaly of short duration with anemia, I kept the possibility of malaria as the first diagnosis, and the child underwent investigations on the same lines.
Why did you keep a possibility of typhoid? Your splenomegaly was how big?
So
6 centimeters. Is that usual for typhoid? Typhoid, you don't get that huge a spleen ever.
And generally it is a soft spleen, so it is lower down in the...
I was surprised to hear that as a differential. Yes, it could explain your bone marrow suppression, it could explain your anemia to an extent, but usually typhoid would cause more leukopenias than anemia. Anemia would take a longer time to come up with. So I was little surprised at that additional differential which you added. So how are you going to planning to, what investigations were sent?
So firstly the child underwent hemogram with peripheral smear which showed pancytopenia in our case. The hemoglobin was 6.6, TLC was 2100 and platelet count was 85,000 with a normal MCV ruling out vitamin B12 deficiency or folic acid deficiency leading to pancytopenia. The other investigations sent were PS for MP and RMAT to rule out malaria, which turned out to be negative. Vidal was sent, which was non-reactive. Blood culture came out to be sterile in our case, and the viral markers for hepatitis were negative. HIV was sent, it was non-reactive. Chest X-ray and MON2 were ordered, and chest X-ray was normal. GA for AFP was sent, it was not showing any acid-fast bacillus. The coaglogram was done, which was normal. And the CBC with PS with retic showed no atypical cells or parasite. And it showed normocytic normochromic anemia. Keeping the possibility of...
of the differentials which you had kept, what all was ruled out by these tests?
So malaria was ruled out, then malignancy, because pancytopenia of this extent with no atypical cells in the CBC with PS is unlikely to be a malignancy.
And you said bone marrow was also normal.
So bone marrow was also done, it was normal.
Okay.
Sir, then enteric was ruled out, and for hemophagocytic HLH, the possibility kept was ruled out since the fibrinogen turned out to be normal and ferritin was normal in our case.
You didn't have any evidence of hemophagocytosis
in bone marrow itself. So then ultrasound was done to see for the ecotexture of the liver and spleen, to see for any intra-abdominal lymphadenopathy or ascites, though we didn't get any ascites in our examination, and to see for the splenoportal axis. The Doppler was done. In the ultrasound, the report which turned out was the liver was 12.9 centimeters with normal echo, which showed no place occupying lesion. GB, gallbladder, portal vein and CBD was normal. Spleen was enlarged. It was so much so enlarged that it was reaching up to the hilum of kidney and was measuring 12 centimeters. It showed multiple hypoechoic lesions of variable size, the largest being 2 centimeters, and the lesions were scattered throughout the parenchyma of the spleen. There were no significant lymphadenopathy or free fluid or bowel pathology seen in the ultrasound, and the splenoportal axis was normal. It didn't show any portal hypertension features. So the ultrasound report was we had splenic granulomas or abscesses on the ultrasound, and investigations in the form of CCT abdomen and histopathological diagnosis was advised, and we underwent the patient underwent CCT abdomen, the image of which can be seen.
Why did you go for a CT scan?
So, because there was no to rule out other pathologies like lymphoma, whether it is lymphoma or infectious cause, because in this we just had multiple variable sized hypoechoic areas and the other structures which we saw were normal. So to better delineate the structures and to see for the pathology, we went for CT scan.
Okay. Dr. Puneet, would you like to explain?
Okay, so on the left side we have an image transfer section of the abdomen which is showing spleen over here, and it is showing multiple hypodense lesions scattered throughout the parenchyma, and we see they are variable sized. Some are larger, even larger, and some are smaller in size. So this variable sized hypodense lesions scattered throughout the spleen was suggestive of splenic TB in this particular case.
So this one, we did not have a confirmatory diagnosis. Did we attempt any confirmatory diagnosis?
Sir, the consent, we planned a percutaneous CCT guided FNAC of this child, but the consent was not given, and also since the BMA report was normal in this case and the CBC with PS was normal and the child already received antibiotics, this is a retrograde diagnosis, the child already received 2 to 3 weeks of antibiotics in our hospital. After that, and the child had non-tender splenomegaly. The differentials on the basis of CCT abdomen and ultrasound kept were tuberculosis firstly, then lymphoma, then pyogenic abscesses. The examination and the history and the treatment suggested that it can very well be tuberculosis. As Dr. Puneet rightly said, the lesions were variable sized, defined and scattered throughout the spleen, and the child had positive MON2 also. We started the child on category 1 ATT and the child responded to the same.
Did you try for the microbiological diagnosis as you did in the previous case?
Sir, we tried, but the percutaneous CCT guided, also the child had pancytopenia also in our case, so low platelet count was a hindrance.
I'd like to explain better. So as she said that Dr. Bhavna said we had a 7-year-old child with...
Let me ask one question.
Right.
What would you keep a possibility of a bacterial abscess in this child, and on what basis?
That was the diagnosis the ultrasonologist gave us, right? This child had very high grade fever, spiking, but counts were normal.
Normal counts.
Right. So would you keep a possibility, clinical possibility of a bacterial splenic abscess? Yes? Pyogenic abscesses are usually very tender, which this child did not have, so that's one point against. I agree with you. Anything else? Isolated pyogenic abscesses of the spleen, are they common? When do you get it? In what situations? I think this is where your review comes into being.
Right,
And
right,
let's
right.
hear quickly about both these cases and their uniqueness in diagnosis from Dr. Puneet.
Right. Thank you, sir.
I'm sorry I'm interrupting you again, but I see there are a couple of questions which people have raised. One is whether gene expert can differentiate between live or dead bacilli. No, it does not. So if your point of reason for asking this question is that if it was an old healed case and now we have tabbed abscess, how do we know that it was not a spontaneously healed case? These were new lesions, new problems which had come up in this child. She had fever and therefore everything to believe that this was an active case of tuberculosis. Clinically active case of TB, demonstrating DNA, alternative diagnosis ruled out, therefore possibility remains tuberculosis in this situation. Otherwise, molecular tests like gene expert or expert RIF do not differentiate between live and dead bacilli, and that is why we do not use this test for follow-up. The follow-ups are always done by cultures and not by gene expert, because that is not the answer you're looking for. The benefit of gene expert or expert RIF or CB NAT lies in a quick early diagnosis confirmed of MTB or associated RIF resistance, which is considered as a surrogate marker for MDR TB in our country. Okay. The other question which was asked about was about the neuropsychiatric manifestation of the first child. As we said time and again, it was the frontal lobe tuberculoma which we saw in this child. This was the possible explanation for her neuropsychiatric illnesses. I hope those questions are answered. And over to you, Dr. Puneet. I hope I don't have to interrupt you now.
Thank you, sir. I'll go to the review of the second case first, since you're fresh with it. So, to summarize, that was a 7-year-old male child with acute febrile illness of the past 10 days, with splenohepatomegaly, with severe pallor, and with ultrasound and CE-CT suggestive of multiple splenic hypodensities. So, what all possibilities could we think of? One possibility would be that the entire system was plagued by the same disease, that is, the fever and splenic lesions were of the same disease, of the same origin. The causes other could be that the fever was from a separate infection and splenic lesions were just an incidental finding. So fever due to splenic lesions was a more likely cause, and we had no other etiological clues to diagnosis. It could be a splenic abscess, which could be pyogenic, tubercular or fungal. It could be lymphoma. It could be metastasis or parasitic cyst. These could lead to fever due to splenic lesions. And fever with incidental splenic lesions could be secondary cyst, hemangioma, hematomas or splenic infarction, which appears less likely in this case. Of these, the two things that we were confused were tubercular and lymphomatous lesions. Radiological characterization of these lesions helped us to narrow down to two of these lesions. As we see the contrast between these two images, in splenic TB, the lesions are variable sized, whereas on the right side we see lymphoma lesions which are all similar sized. Tubercular lesions are larger in size, whereas lymphoma lesions are usually less than 1 centimeters. Conglomeration of lesions is usually seen in splenic TB. So based on the radiological findings that we had, we thought that splenic TB was the more likely possibility. But still we had other possibilities to think of. Bacterial abscess, as we were already discussing, the child was less toxic. He was not toxic actually. The abdomen was non-tender. There was no leukocytosis, there was leukopenia. And there was no other pyemic focus which was present in this particular child. There was no isolation on the blood cultures. And despite almost 16 days of broad spectrum antibiotics, the child did not respond to the fever. The second possibility would be a tubercular abscess. There was no direct or indirect evidence of TB, And the third possibility of lymphoma, radiology placed it as at a lower down possibility, plus the child had no lymphadenopathy. Isolated splenic lymphomas are rare, less than 2% have isolated splenic lymphomas, and CECT densities were not very suggestive. So we should have ideally gone for an FNAC, but the lesions were multiple, they were deep-seated, and the splenomegaly was massive. So when we explained the risks to the parents, they refused consent, and therefore an FNAC was not done. Coming to the epidemiology of splenic abscesses, only 600 cases have been reported worldwide till 2006, so it is rare. Splenic abscess is not common, especially when present in isolation. The risk factors for splenic abscess, it could be a contiguous spread. Suppose someone has a gastric abscess or a subphrenic abscess, pancreatic abscess or colonic abscess, it can spread contiguously to the spleen. The other is hematogenous embolization to a normal spleen. So the child has a normal spleen, but if he is immunosuppressed, for example, he is a bone marrow transplant recipient or a renal transplant recipient, or he is immunocompromised as in he has HIV or some primary immunodeficiency disorders, in those cases splenic abscesses have been noted and reported. The third is hematogenous spread to an altered spleen. The child is not immunocompromised or immunosuppressed, but the spleen parenchyma per se is altered in the form of splenic infarcts, hemangiomas or cysts. The causative organisms that have been found include 33% of gram-negative organisms, 27% of gram-positive. TB has been reported in less than 5% of the cases of splenic abscesses. So clinical features, most common is fever, which is present in 90 to 95%. This was present in our case. Left upper quadrant pain is present in 40 to 50%, which was typically absent in our case. Splenomegaly is also present in 50%, and left-sided pleural effusion is present in almost 20%. Apart from that, hepatomegaly, hypersplenism and constitutional symptoms can be present. Our child had pancytopenia, which we could have explained by hypersplenism. So diagnosis of splenic abscess, we need blood investigations. Blood cultures are seen to be positive in around 60%. Imaging, we have X-rays which may show left diaphragm elevation. Ultrasound, which will show hypodensities in the spleen, and it has a sensitivity of 75 to 85%. However, the investigation of choice is CECT scan to find out splenic hypodensities and better delineate it. Confirmation is by histology, ultrasound guided FNAC or culture of the lesions. In case of tuberculosis, it would show granulomas, and AFB can be seen on ZN scan, and still better sensitivity of CB-NAT. Splenic TB and disseminated TB, spleen is the third most common organ involved. So when we talk of disseminated TB, spleen is the third most common organ involved, following lung and liver, but isolated splenic TB, as was the case in this child, is rare. Only case reports are known, and those two mostly in adults. Tissue diagnosis is confirmatory. Previously, surgical management and drainage was sought, but in the more recent case reports, conservative management has been done. Our child also was conservatively managed, and he did show improvement hematologically, clinically and radiologically. I would now move on to the first case that we had of TB. I would like to focus specifically on the retropharyngeal abscess that this child had. Just to tell you the anatomy briefly, when you look at this figure, this is the sagittal section, these are the cervical vertebrae. And over here, this is the pharynx and the aerodigestive tract, the trachea, and posteriorly the esophagus. So in between these two, that is the cervical vertebra and the pharynx, we have a space which has two layers of the cervical fascia. Just in front of the cervical vertebra is the prevertebral layer, and just behind the pharynx is the buccopharyngeal fascia. So between these two layers is the retropharyngeal space. So when lymph nodes in this particular space developed abscess, it is known as retropharyngeal abscess. And when in between the vertebral bodies and the prevertebral layer an abscess develops, it is known as the prevertebral abscess. So retropharyngeal abscess can be diagnosed on an X-ray. At the level of C2, the retropharyngeal space is twice the diameter of the contiguous vertebral body. So you look at the soft tissue densities, and when it is more than twice the diameter of the level of C2 vertebral body, it is enlarged and suggestive of an abscess. Sir has already mentioned about this, the differentiating factors between bacterial and TB retropharyngeal abscess. Bacterial retropharyngeal abscess is common. You should know it mostly occurs in 3 to 4 years of age because retropharyngeal lymph nodes mostly involute after 5 years of age. So only 3 to 4 years of age would be the peak age for presentation of retropharyngeal abscess. The risk factors for these is that if the child has URI, because the oropharynx ultimately drains into the retropharyngeal lymph nodes. So URI, dental infection, or if there is a penetrating trauma or vertebral osteomyelitis. In those cases, a retropharyngeal abscess can develop, whereas in case of TB, immunodeficiency and malnutrition have been found to be the risk factors. Bacterial retropharyngeal abscess is mostly polymicrobial. In a TB retropharyngeal abscess, the child would be non-toxic. However, the features of respiratory distress and compromise can appear because of compression symptoms due to retropharyngeal abscess. These were typically absent in our child. Whereas in bacterial retropharyngeal abscess, the child would be toxic. In bacterial retropharyngeal abscess, as Sir rightly mentioned, IV antibiotics are used, but whenever we find that it is not responding or it is causing significant symptoms of respiratory distress, a surgical drainage is required. It is said that more than up to 50% of these children with bacterial retropharyngeal abscess require surgical drainage. But in TB retropharyngeal abscess, ATT is the line of treatment that has been used unless the abscess is causing significant respiratory distress or has rupture and causing other symptoms. So TB retropharyngeal abscess is rare. Clinical features can be neck swelling, neck stiffness, dysphagia, respiratory distress or stridor. None of this was present in our child. It was diagnosed on the chest X-ray and later followed up and confirmed by CTs and MRI. High mortality rate of complications occur, as you saw that the retropharyngeal space anteriorly has the trachea, so airway obstruction can occur. Because this retropharyngeal space downwards communicates with the superior mediastinum, so mediastinitis can occur, aspiration, pneumonia if it ruptures. Also, if the jugular vein is involved, it will cause jugular vein thrombosis and erosion of the carotid artery and necrotizing fasciitis. Important to note is that if any of these complications occur, there is a very high mortality. Diagnosis on X-ray, as I've already told, CECT is confirmatory, which will show central lucency, which was present in this case with ring enhancement and scalloping of the lymph node walls. Treatment was conservatively done in this case, ATT, and surgical drainage has been done transoral or lateral cervical if respiratory distress occurs or failure to respond to antibiotics is present. So another focus that I would place on this case is that this child had multidisciplinary approach. Despite the fact that the retropharyngeal abscess was large, it was decided not to drain it because she did not have any symptoms, and as Sir said that it was communicating with the paravertebral and prevertebral abscesses, so there was a risk of transmission of infection peroral to the spinal cord. Neurosurgical intervention was not required at that time. These are the indications that we have for neurosurgical intervention in cases of a pot spine. If it is an advanced case of neurological involvement, like there is sphincter disturbances, which was not present, there's flaccid paralysis, complete lack of power, or severe flexor spasms. So advanced cases of neurological involvement. Secondly, if there are pressure effects, like deglutition is difficult or there are respiratory difficulties. The third is if there is spinal deformity with instability. So you have an impending unstable spine which can suddenly decompress the spinal cord in that case. And if the child is already on ATT and he is showing no progressive recovery after 3 to 4 weeks of trial of ATT, or on ATT there is worsening of neurological deficits, or the recurrence of neurological complications, all these become the indication for surgical management and neurosurgical intervention in cases of pot spine. That's about it. Thank you.
Thank you, Dr. Puneet. And that brings us to the final stages of today's webcast. I have a couple of questions I need to address to. One question is about what samples which we have got through from other centers. One question which I have been asked is what samples are to be taken for gene expert. For expert RIF, you can take any biological specimen which is representing the pathology. So if you have a lung pathology, you can take induced sputum, you can take gastric aspirate, you can take bronchoalveolar lavage. If it is a closed lesion and you have aspirated through a true cut biopsy or a needle aspiration, that can go. A pleural fluid can go, ascitic fluid can go, CSF can go, lymph node aspirate can go. If it is small in amount, you can add small amount of saline to dilute, make it so that it doesn't dry on the way. The limit of detection of this test is about 150 colony forming unit. That means you need about 150 copies of DNA in a specimen for it to be picked up by gene expert. The limit of detection by culture is about 100 copies. So that is why culture are little better than gene expert, because you need about 10,000 copies of colony forming units or bacilli in a smear to it to be a smear positive. So that way from 10,000 it's about 150, which is, that means even in paucibacillary the yield will go up, but still not as well if the number of bacilli are less in a given specimen per ml. So the variety of specimens which can be subjected to gene expert are huge. There is a digestant which is supplied by the company, and you add that to the specimen and then it is put into the cartridge. And I must also inform the gathering from all over the country that Government of India also has under a project got what is called as an impact lab. If you run this word on the Google search or any search engine, you will get those list of the labs which are available all over India and provide a subsidy on this test. So this test Gene Expert is available. If it is not available through the public health channels otherwise to you, you can always go through the alternative channels in the private sector at a much cheaper cost, because TB is one disease which is disease of the poor, and therefore cost always remains an issue. The other two questions which I have been asked are, related. They are about our second case on splenic abscess, about whether it could be brucellosis. Usually brucellosis would be, the triad would include arthritis, severe pains in aches, which our current case did not have. They are usually micro abscesses and multiple. Ours had a large abscess of about 2 centimeter. If you read Nelson, it does always say that brucellosis and tuberculosis are differentials of each other. But looking at the total picture, a non-tender splenomegaly, one single large abscess with other discrete satellite lesion and not micro abscesses. When Dr. Puneet showed you that picture, on that picture, deceptively the two lesions look quite similar. But what if you can go back to that lymphoma? Yeah, but you see the lymphoma one is hugely enlarged spleen which you are seeing, and the other one you are seeing liver and spleen, and actually that what is looking of a similar size, the sizes are very different, and that is true even about other micro abscesses when it comes to non-tubercular pyogenic abscesses, which are because of the septic emboli or micro abscesses which form, and therefore we did not consider brucellosis as a possibility. Can we be 100% certain? Possibly not, because brucellosis also responds to rifampicin. We do not have a bacteriological diagnosis. Between the two, looking at the presentation, we thought, in the absence of transaminitis, in the absence of raised CPK, in the absence of arthritis, in the absence of a severe myalgia, the possibility of tuberculosis more likely clinically than brucellosis. But Dr. Palani Raman, you are right. This is a good differential to keep in mind. So I hope you all enjoyed this session as much as we did, and I thank Dr. Bhavna, Dr. Puneet, Dr. Mukesh and Dr. Kamal for helping me out with this session, and I hope it helps everybody else to learn. It was interactive. We got few questions, and I finally end by saying thank you and happy Onam to all of you. Thank you very much.